All right, so I'm pleased to introduce today's speaker, Dr. Paul Ndebele. Paul is a senior research regulatory specialist at the Office of Research Excellence at George Washington University School of Public Health, where he's also a professorial lecturer in the Department of Global Health. Paul, I've known Paul for many years now. Paul was I guess many years ago in 2000, 2001, one of our first Fogarty Fellows in Bioethics at Johns Hopkins from Zimbabwe, where Paul is originally from. And Paul has spent, prior to his time at George Washington, had spent, what was it, 5 years, I believe, Paul, at Zimbabwe as the director of the Medical Research Council there in Zimbabwe, where prior to that, Paul had served at the NIH as a contractor with NIAID, Division of AIDS, and had a number of other positions prior to that, including at the University of Botswana, where he was the Associate Director for Research Ethics, and prior to that at the University of Malawi, where he worked very closely with colleagues on developing the bioethics programs. So maybe with that, Paul, I'll hand it over to you and let you introduce the topic, which is ethical challenges in defining the appropriate prevention package in HIV prevention research.
Yes, thank you very much, Joe. Good day, everyone. Good morning, good afternoon, good evening, wherever you are. So it's morning this side. So it's great to join all of you on this webinar to share some views concerning ethical challenges in defining the appropriate HIV prevention package in HIV prevention research. Next slide. So, why did I settle for this particular topic? So one thing which is very, very clear is that HIV prevention trials present some serious ethical challenges as they mainly focus on HIV uninfected individuals. So basically you start off with a group of people who are not infected with HIV, and then you introduce your intervention, and then you are observing what's going to be happening to those individuals. So in reality, if we are to honestly speak, it actually means that exposure to HIV infection is a prerequisite for successful testing of an HIV prevention intervention. Without that exposure to HIV infection, it actually means you cannot successfully test that new intervention that you'll be working with. So in reality, as I mentioned before, at the beginning of the trial, we start off with a pool of uninfected persons, and then at the end, some of them will be infected. So there are lots of questions regarding those who seroconvert during the trial. I'm going to look at some of those questions as we proceed, including the question whether the trial itself increased the risks of infection for that individual who will be participating. So I'm going to try and go into detail with that particular question. So in trying to address those questions, as society, we now emphasize on an HIV prevention package that I'm going to be talking about in terms of how researchers and others should decide on the components that are going to be used in a specific HIV prevention trial. Next slide. So in this session today, I'm going to talk about HIV prevention trials and also the prevention options that are available. And then, of course, define an HIV prevention package within the context of an HIV prevention trial. And then I'm going to look at the ethical implications of an HIV prevention package. And then, of course, try and look into justifications why a prevention package should be part of a research protocol. I'm then going to look at some international guidance documents on the HIV prevention package to see what guidance they provide to investigators, sponsors, and others. And then try and look at that question of what should be included in the package. And then eventually, I'm going to look at who should be involved in decisions on the appropriate HIV prevention package for the specific trial. Next slide. So if we look at the issues around HIV prevention package, this takes me back to the early microbicide trials. I remember during the early days of the microbicide trials, I actually participated in the review of one of the earliest trials involving nonoxynol 9. And during those reviews, there were lots of discussions around investigators watching whilst individuals become infected. Because basically what this means is that as investigators, you are aware of the status of that particular individual. And as you are collecting your data, it's as if you are simply watching as that individual is living their normal life, engaging in risky practices until they get to that point when they are infected. So this brings then the question, what is your role in the life of that particular person? This then also led to discussions around access to treatment for those who seroconvert during the trial. I'm going to look at some of the difficult issues when you're actually looking at HIV prevention trials. If we look at the other trials that came later, the PrEP trials, these included condoms and counseling as standards. But we realize that these are not difficult issues because basically lots of governments across Africa have been providing these to the general populations. So it might not be difficult for research teams and also sponsors to chip in to ensure improved access to those options. And now when you look at the vaccine trials that are going on, things have changed because of PrEP, which is kind of the new kid on the block. It raises different questions altogether. So I'm going to try and look into some of those questions. Next slide. So if we look at the prevention tools that are available in our basket, we've got several options that are already in use, starting off with the male condoms, the most popular option, HIV counseling and testing. We also have behavioral change. We also have the female condoms, but we also are aware that treatment of STIs assists in terms of preventing HIV infection. We also know that studies have proven that voluntary male medical circumcision also assists in reducing chances of infection. We are working on microbicides. We already have PrEP, which is already being used, but we also have PEP, which is a post-exposure prophylaxis. But we now know that with treatment, if we provide treatment for HIV, it also reduces the chances of spreading HIV to others. So basically in all, we are looking at sexual prevention. Now, if we look at the various biomedical interventions, these include some that I've already mentioned. We are looking at the HIV testing services, the male and female condoms, PEP, and also PrEP, treatment as prevention. There are various important methods that are already being used within our various countries. Next slide. And then there are also behavioral interventions that are already being used in various countries. For example, information and raising awareness, risk perception, education to individuals and communities. There are also the messages around correct and consistent condom use, but we also have other programs that are looking into substance abuse mitigation. We have got schools programs on sex education, which is aimed at preventing risky behaviors amongst those who attend schools. Next slide. There are also some structural interventions, for example, those that aim to reduce vulnerability and victimization. We can actually look into those that focus on gender, social and cultural norms change. We can also look at those that focus on economic empowerment. We can also look at some that focus on human rights protection. We can also look at some that focus on stigma reduction. Next slide. So now we are aware that if we're going to have effective HIV prevention, we need a combination of prevention options, focusing on throwing in some biomedical interventions and also behavioral interventions and structural interventions. So if you're actually taking a helicopter view of what's happening on the ground, you're going to realize that in the various countries, there is a combination of the various options that have been thrown in there so that each one is contributing some aspect to the fight towards preventing new HIV infections. Next slide, please. If we look at the current standard of prevention practice, when we're focusing at the general population level, we've got national HIV prevention programs, usually involving the provision of male condoms and also female condoms on request, HIV testing and counseling, safer sex counseling, and also treatment of sexually transmitted infections through the ministries of health or through NGOs, but also provision of or referral for voluntary male circumcision. So basically, these are typically offered through the ministries of health or NGOs. But now when we're looking at HIV prevention trials, I would say that there are 4 important ethical issues that we always need to be thinking about. One of them being the standard of prevention. So basically here, we're looking at the risk reduction package provided to all participants in a trial, comprising measures used to help minimize the risk of HIV infection. So we're going to be focusing on that particular element in this talk. But we might also look at ancillary care, which is healthcare which is provided to trial participants for conditions that are not directly associated with the research question. This is a question that we are always posing, even as research ethics committee members or as communities. There is also the question of the standard of care, which may actually refer to the proven effective intervention which is provided as the comparator arm in a trial to which the experimental intervention is being compared. And again, the standard of care, here we were looking at HIV prevention that will be provided to trial participants who self-convert during the course of the trial. So we're looking at different issues here that we need to clearly think about when we're introducing a new HIV prevention study. Next slide. Of course, there are important questions that we need to be thinking about. One of them being, what should be included in the HIV prevention package available to the research participants? Secondly, we need to be asking, whose responsibility is it to provide the various components that we'll be thinking about? Thirdly, we need to be asking, should we include newly established interventions in ongoing trials? What are the implications? And more importantly, who should make the decisions? Next slide. Now, we need to ask ourselves the question, why should research participants be granted access to HIV prevention package? So if we are looking at our ethical principles, this is grounded in the ethical principle of beneficence, where we are saying that we need to maximize benefits for those individuals who are contributing towards the generation of new knowledge on HIV prevention. But we are also trying to minimize harm for those individuals. So basically, if we're looking at this obligation, it extends beyond the intervention which is being studied, but also to reducing the risks for those individuals. So we're now looking at non-maleficence, which is about removing evil or harm. So in this particular case, by providing the prevention package, we are removing evil or harm. Some may actually look at the risk as the normal daily risk, but it's also possible that the trial may also add to the risk by creating a sense of false confidence. But it's also even possible that the option which is actually being tested might actually increase the risk for the individuals who are participating. For example, with the nonoxynol-9 trials that I mentioned earlier on, the findings actually demonstrated that the new option which was being tested actually increased the chances of infection for the women who were participating. But you can also look at this from the justice perspective, where we are looking at the issue of fairness for the disadvantaged populations. So basically here we're looking at providing access to prevention options through the study. There are lots of papers that have been written regarding how individuals in resource-limited settings actually utilize research participation to access healthcare. But we can also look at the availability of the prevention option to participants as something that we are saying to them, thank you. So we're recognizing their sacrifice. So we're saying, in exchange for the sacrifice that you are making, we are also taking care of you by providing this HIV prevention package. Next slide. One other thing that we also need to be thinking about is the fact that HIV predominantly affects the less resourced communities. So this again is part of a justice argument. But more importantly, HIV prevention trials present a dilemma for the researcher. You see, the researcher who is going into HIV prevention research is also a healthcare specialist. As a healthcare specialist, you also have a role to protect individuals. So here we're looking at the role of the healthcare specialist to these individuals who are participating in their research. And yet at the same time, you are interested in collecting data from this particular individual who clearly needs to be exposed to some HIV infection for you to successfully test your new option as a researcher. So basically, the HIV prevention package addresses some of these concerns around that conflict of interest, but also concerns around false inhibitions or the false confidence that might crop into trial participants who might actually feel that by participating in an HIV prevention trial, they are better protected. There is some anecdotal evidence of false confidence in HIV prevention trials. For example, I heard of a case of a group of women in Malawi who were participating in a microbicide trial. So they got to know that some of them were getting the placebo, while some of them were getting the active product. So these women then decided to share the benefits. So during the day when they were going to the center to collect their supplies, after collecting, they would meet under a certain tree at a specific time. And then one of them would bring a huge basket, and then they would all throw in their supplies. So these are placebos and the active product supplies. They would throw them into that huge basket, and now they shake that basket, and now they would go around, the basket would be going around the group of women, each one picking. In that way, they were actually thinking that they were sharing something which was going to be beneficial to them. And yet the results actually proved that what they were sharing was actually harmful to them. There are also examples of commercial sex workers who were participating in some HIV prevention trials who were now agreeing to engage in unprotected sexual contact after being offered a bit more in terms of cash, because they were participating in this research. So now they were feeling at least they were using something which would actually protect them. And yet they were protecting in the testing of an intervention which was yet to be proven. So there are some studies that have been conducted there that have actually concluded that there is no false confidence amongst trial participants. But for me, I always want to err on the side of caution and say we need to be thinking about individuals. It might not be very significant at the group level, but it might actually be significant at individual level. So we need to be thinking about individuals and not necessarily focusing on the whole groups. Next slide. So there are two interesting papers which were written some time back. There's one on ethical considerations in determining standard of prevention packages for HIV prevention trials, which was examining PrEP. So this was also in the context of PrEP. So this was 2013. There was also another one that we co-authored with some colleagues from the NIH, which was on testing the waters, ethical considerations for including PrEP in a phase 2B HIV vaccine efficacy trial. So when we were writing these papers then, PrEP was just the new kid on the block. So we're now trying to look at the question now that there is evidence that PrEP is effective. What should be the scenario for new HIV prevention trials, but also for ongoing trials? Should they be adding PrEP into their prevention package? So even as we're thinking about these questions then, even right now in the area of HIV prevention, there are others who are already beginning to throw in these questions when they are now focusing on discovery, which is now also the new kid on the block, when we're particularly focusing on men who have sex with men. It actually has lots of advantages compared to Truvada. So some are already asking the question, should we now be including discovery into the existing trials that are dealing with MSM? Next slide. Regarding this conflict of interest that I mentioned earlier on, so the HIV prevention package goes against the primary role of researchers, which is to gather knowledge. So this raises the questions in terms of how researchers and sponsors address it. I'm going to look into some of these issues as we proceed. Next slide. Now, we also need to look into the ethical implications of HIV, the HIV prevention package. And we need to appreciate that both the prevention package in trials and the inclusion of a new HIV prevention option have profound impacts on design feasibility and the ability to interpret HIV prevention trials. So these days, HIV prevention trials are so complicated that you need lots of people to come together and think about how they design these and also how they're going to interpret the results because of the HIV prevention package. So trial designs have to factor in additional endpoints and also even larger sample sizes. We need to always be aware that our regulatory authorities actually stipulate the level and strength of evidence that is required for them to license some products. So these days, there are always some wide consultations during the trial designs with the regulators because there are all these issues about adding the various components into the prevention package, which make interpretation of HIV prevention trials more complex. Some actually view the prevention package as presenting potential for undue inducement. So they're saying that when we actually offer the prevention package to trial participants, we are actually trying to attract them into the research But some are always quick to point out that for someone who is HIV negative, they are not necessarily hoping that they are going to be to become infected. So they are not actually thinking at that as a benefit. They are simply thinking about participating as a sacrifice that they are offering as an individual. Next slide. There are some tensions that are associated with determining the standard of prevention package for HIV trials. HIV prevention trials, I'm going to look at some of those as we proceed. But we need to be cognizant of the fact that it can be ethically and practically challenging to determine the content of the prevention package and how it is going to be availed. So there are two different issues we are looking at here, which is the content and also how the content is going to be availed to the trial participants. Over time, we've realized that it is easy to agree on some options. For example, condoms and counseling and HIV testing, because these are the standard options that are availed in the various countries through the ministries of health, the HIV programs in those countries, and also through the NGOs in those countries. But you also need to realize that including some options for multi-country HIV prevention trials may be complex. For example, let's say as the countries are conducting one big trial, different countries, they actually approve this new intervention at different stages. We actually saw this with PrEP, that countries actually license PrEP at different stages. So the research cannot just adopt PrEP as a component in their prevention package before it has actually been licensed within that particular country. So already we are looking at some issues here in terms of interpreting those findings, but there is also an element of some injustice here in that participants from other countries are now accessing a better option, whilst others in a country which is slow in terms of approving or licensing this option do not have access to that particular new option. As I mentioned earlier on, there might be concerns about interpretability of the study results because of the differences in terms of how the new option is going to be introduced. And of course, as I mentioned, the concerns around double standards. Next slide. So in terms of the guidance, I'm flagging here these three important documents. So for the UNAIDS WHO guidance document, there was the first version which was issued in 2007, and then the next version which was issued in 2012. So basically there were some additional guidance points that were added in 2012. And then in February of this year, that's 2020, HIV Prevention Trials Network then issued their own guidance document. But regarding the UNAIDS guidance document, it's currently under review. And I was fortunate to participate in a meeting in, I think it was in November this past year, which was actually focusing on revising the document from 2012. So I'm going to be discussing some of these issues. So right now, the UNAIDS document is still in draft form, and UNAIDS is actually inviting interested individuals and organizations to provide feedback on the guidance document. Next slide. And from the UNAIDS 2012 document, specifically guidance point number 13 is to do with standard of prevention. And this actually emphasizes that the standard prevention package should actually be an integral component of the research protocol. But I want to highlight or emphasize on the point that it was actually emphasizing that the participants should be granted access to all state-of-the-art HIV risk reduction methods. If you look at that statement there about all state-of-the-art HIV risk reduction methods, it's actually loaded and it raises lots of questions. So now, as you know, we are going through the process of revising, these are some of the issues that we're trying to address to ensure that this is not an open check. This is something that cannot be taken advantage of. It also emphasizes that new HIV risk reduction methods should be added as they become available based on consultation among all research stakeholders, including the community, as they are scientifically validated or as they are approved by relevant authorities. Next slide. And then if we look at the HPTM document from this year, particularly guidance point number 9, which is on standard of prevention, it emphasizes that HIV prevention researchers should partner with key stakeholders to provide a package of effective, comprehensive, and sustainable prevention services to all participants. I want to emphasize the element of partnering with key stakeholders. So basically the idea here is that the researchers and the sponsors should not be doing this alone, but they can actually partner with other agencies or partners who can actually provide some of those components. So basically this document emphasizes the ethical obligation of providing the prevention package. But then when they look at aspirations, they are looking at the content of the prevention package. What are you going to include in that prevention package? And basically they're encouraging that that prevention package should be better than what is provided locally in that particular environment. And it emphasizes that the study team and the sponsors are responsible and accountable for ensuring access to the standard of prevention package. Next slide. So if we look at the HPTM document, these are some of the issues that it emphasizes on, that the package should be pragmatic and context sensitive, and that it should be practically achievable as a standard in the local context. So it emphasizes so much on the local context, and it also emphasizes that it should be reasonably accessible to those at risk for HIV. It also emphasizes that it should not be so superior to available options so that you avoid making it an undue inducement, but also emphasizes that it should not be substandard compared to what is available to the public. So basically I'm saying it shouldn't be too high, it also shouldn't be too low. So basically I'm aiming at something which is above what is being availed to the public. Next slide. And then now coming to the UNAIDS 2020 draft, which is currently under review, particularly guidance point number 12, which is also on standard of prevention, emphasizes that research teams and trial sponsors should, at minimum, ensure access to the package of prevention methods recommended by WHO for every participant throughout the trial. I want to emphasize here the minimum standard that they are emphasizing on, that as long as something has been recommended by WHO, then it should be thrown into the package so that it's available to the trial participants. And they actually emphasize that this should actually be availed to the trial participants even before they are enrolled. So when you are, before you've started the randomization, you want to ensure that they are already having access to the prevention options. They also emphasize that a departure from this standard can be justified only if relevant stakeholders, inclusive of community stakeholders and the Research Ethics Committee, are meaningfully engaged and accept a compelling scientific or biological rationale for the departure from the standard. Here I want to emphasize the responsibilities that are placed on community stakeholders and the research ethics committees. They also mention that when WHO recommends new HIV risk reduction methods, they should be added to the standard of prevention. So basically the issue here is they are now saying once WHO has made a recommendation, then it's time for researchers and sponsors to add that particular new option. So basically they are trying now to address some of those areas of weakness from the 2012 and 2007 guidance document. Now, when you try and compare, excuse me, what is coming from the UNAIDS 2020 draft document and what's coming from the HPTM guidance document, you are going to realize that UNAIDS is actually aiming at providing some minimum standard as guidance. And then the HPTM document provides lots of flexibilities. And that should actually be understandable because the HPTM guidance document is actually an in-house document that has been developed by a network to guide researchers within that specific network. And if you look at the UNAIDS document, it's actually, having stakeholders from all over the world coming together to look into how the standard of prevention package should be addressed. Next slide. So there are areas of agreement. If we look at the UNAIDS and the HPTM, there is general agreement that the prevention package should be offered. And also that the prevention package is a part of the protocol, and also that there should be consultation among all stakeholders, and also that the components should be scientifically validated and approved by relevant authorities. Both documents agree that there could be various modes of delivery that can actually be brought into the particular study. Next slide. But now, when we look at the differences, UNAIDS is planning to emphasize on WHO recommended options, while HPTN allows for flexibility. And UNAIDS is also clearly stating that any departure should be justified to the stakeholders. And specifically, I want to emphasize that UNAIDS draft gives research ethics committees the role of checking on researchers and sponsors and approving the prevention package, and also even monitoring how it's being implemented. Next slide. And regarding placebo use, for some of us who have been reading about issues on placebo use, I just picked this from the UNAIDS draft guidance, which says that, I can't remember which point it is, but it mentions, I'm reading actually directly from that, which says, the use of placebos can be justified only if the recommended standard of prevention is provided to participants in both the control and the experimental arms as per guidance point number 12. So basically what they're saying is that as long as everyone is assured of access to the prevention package, then researchers and sponsors are free to use placebos in research. Next slide. But there are several unanswered questions. These guidelines do not discuss researchers' responsibilities in ensuring adherence to the various options. It's one thing to offer Truvada or PrEP, but it's another thing to ensure that the participants are actually utilizing it. So for example, if a project is providing PrEP, how far should they go in promoting its use? Mind you, I mentioned the issue of the conflict of interest earlier on. So here it's coming up again. If they find out that the participants are not practicing safe practices, what should they do? Should they now be, bringing them in and, reinforcing safe practices, and at the same time knowing that if all these participants are going to practice safe sex, it actually means there is going to be little exposure to the HIV. And so this actually weakens their own study. One other question to ask is, does focus on the prevention package detract from the research roles of collecting the data? So basically, as society, we remain silent on these questions. And my argument is that this is part of the compromise to ensure that researchers can collect useful data. At the end of the day, we want to ensure that the data which is collected is actually interpretable. Next slide. There are some recommendations that have been thrown in through the HPTM document and also through UNAIDS 2012 to address some of those issues. And from the HPTM 2020 document, they are saying that researchers should provide information on the non-effectiveness of the options that they're actually providing through their package. And they also encourage that researchers should actively promote their package. They also even encourage that researchers may serve as advocates for the HIV prevention package. But if you look at all those three, there are actually some ideals. We don't know how far researchers can actually go in terms of each of those three ideals. If you look at UNAIDS 2012, it actually emphasizes that risk reduction counseling should be monitored. But by who? Is this actually happening in practice? They also encourage that counseling should be provided through a neutral agency, and researchers and community should make sure services are of high quality. Again, if you look at these two ideals, there are some questions. If you are looking at that other neutral agency, which agency should that be? Who should be actually funding that? There are lots of unanswered issues there. Next slide. Now, regarding the question of who should be involved in making the decisions, stakeholder consultation is a necessary step, including the government, the ministries of health, the regulators, the research ethics committees, and also community representatives. Here we're also focusing on extensive grassroots consultations about the content of the standard of prevention package for research, even at design stage. And UNAIDS and AVAC have developed good participatory practice guidelines which detail expected engagement processes with communities throughout the life cycle of a trial. And this document describes how to establish mechanisms that give the communities opportunities for input in the research. But in some of these consultations, there have been some problems with some communities throwing in some unlimited expectations at the researchers and sponsors. And I've actually attended one meeting where some of the community members actually walked out because the sponsors and the investigators were not willing to accommodate their demands. But more importantly too, I think we can learn from the HPTM, which has formalized these consultations before the trial and also during implementation as a way of ensuring that the views of the various stakeholders are clearly heard, and the issues around the components of the HIV prevention package are clearly discussed during those consultations. Next slide. So with regards to my final thoughts on the HIV prevention package, I want to emphasize that the HIV prevention landscape continues to define standards for stakeholder engagement. You see that through HIV research, the standards are actually changing because of the demands that are being placed on the research community through HIV research. And I also want to emphasize that as long as we do not have a workable cure for HIV, we will continue to deal with these ethical issues. Right now, we're talking about a few patients who have been cured, but we realize that those cures are not workable as of now at a large scale. So we always continue to have these difficult questions. But we also need to emphasize that a very robust prevention package may compromise the ability to detect the effects of an experimental option. So this is why I actually showed that those silent questions, the questions we are not asking when we are implementing these HIV prevention trials. I have emphasized that HIV prevention trials present a conflict of interest for the researchers. So as society, we need to find ways to address this conflict so that at the end of the day, we can actually conduct research and find ways of minimizing new HIV infections. And all these ethical issues and questions can only be addressed by bringing together all stakeholders, including the regulators, the community representatives, and also research ethics committees. Next slide. Thank you very much for listening.
Great, thank you, Paul, for the stimulating and interesting discussion and talk. I think we have about 10 minutes to 9 minutes for a bit of conversation and questions. So let me just open it up to those in the group and see if there are any questions that have arisen or other kinds of comments. While I'm waiting for others to, sorry, I'm just trying to find my chat here. There we go. Well, if anyone would like to speak, please feel free to either unmute or raise your hand using the Zoom raise hand function. And we can do that, or you can type a question in the chat box. Just a point of maybe minor, I think, clarification on the HPTN guidance. I think you had mentioned, Paul, that the most recent version was released in February 2020, and I think that's right. That's true. There's, I think, 2 prior iterations of that as well, going back to 2003 initially, and then a second version coming out in 2009. So it seems like HPTN and UNAIDS have been working a bit together and in parallel in developing these guidance documents. So
Yes.
they do seem to evolve quite a bit over the years, though.
Yep. Thank you for bringing that up.
Yeah.
I can see Jeremy. Is online.
Yeah. Yeah, Jeremy, I don't know if you...
Yeah, no. Thanks so much, Paul, and thanks for bringing these issues up. I had, because of the COVID-19, my meeting out of the country was canceled, so I was able to join, and I'm glad I did, and I thank you for bringing some of these issues forward. I think there's lots we could talk about, and I don't have any slides, so I don't want to take anyone else's time. But Joe is right. This is the 3rd version of the HPTN ethics guidance document that's been out there. And in this updated version, we have tried to be responsive to several of the changes in the landscape of HIV prevention research. When we first started this, trying to come up with guidelines, we were stuck in a situation when all HIV prevention research virtually was futile. Everything we tried didn't work. And the only thing we had available for standard of prevention were condoms and counseling, pretty much. And fortunately, we had some breakthroughs on prevention of maternal to child transmission. But for over a decade, the field was terrible. I mean, we couldn't do right. And so providing a prevention package in that setting was made complete. You know, it always makes complete sense, but it was easy to negotiate. It was easy to have a global standard. It was fairly easy to implement, and it didn't pose challenges to research. But fortunately, HIV prevention research turned a corner, and we have not only PrEP, which you pointed out, but we have which can work extraordinarily well, oral PrEP in certain populations with good adherence. We also have treatment as prevention. So by treating people who are already HIV infected, we can drastically bring down rates of HIV. And now we have evidence. There are also some initial results on some microbicide trials and some initial results on some vaccine trials, not as much as we'd hoped for. So there are things that are available, but we still want, as you pointed out, to have other preventive modalities available for people because they don't work for everyone. And the real practical problem the HPTN has always faced has been, how do we actually field trials that we can actually do that protect the rights, interest, and welfare of participants, and at the same time are science, and that's good enough science to develop these modalities. And that's the tension we've always faced. And if you want to look at the areas you brought out, I think it's great. It's almost like a big tennis match between UNAIDS and HPTN. HPTN's articulating what can actually happen in practice, and UNAIDS is rightly aspirational, but those things can't be achieved. It's simply no longer feasible to provide all available preventive options. We just can't do it. No one was going to have all of those options, and if all of those things, they may interact, they may undermine the ability to do the science, and if UNAIDS offers a recommendation up, we don't know why that recommendation was made. It could be made for different reasons. And so the current draft, I think, is going to need some work. And it's just otherwise, so we can actually do these trials. We don't want people to be criticized who are approaching these things as ethically sound, in an ethically sound way, and get undermined by a document that suggests that they're doing wrong with every action they take. And so that's the tension. Just one other corrective, and I'll stop, is that the guidance document was developed not only by the network itself, but we have international representation. The HPTN is a global network, and we vetted that document pretty much on every continent, had engagement and critique, which greatly improved the document. So we keep revising it as HIV prevention trials change, normative guidance changes, laws change, the context changes, and we're just trying to make sure that we can do something to stop this epidemic in an ethically sound way.
Yeah, I think I'll let Paul respond, but I think just to add, I think the tension that you and Jeremy have raised, which is this kind of tension between doing good science and doing ethical science. It seems to me like there's a convergence of interests on all sides in terms of reducing infection rates and the desire endpoint there of reducing morbidity and mortality. So it seems like there's a lot of there's still a tension, clearly, but it seems like the more the prevention packages are working, the better off everyone is. It may be a little bit more challenging, of course, to identify treatments as cures and sort of which prevention is most effective and those types of questions. But with the goal of sort of mitigating and minimizing risk and maximizing benefit, there's clearly going to be a need for some kind of more innovative methodologies or whatever it might be to try to tease out more in a more fine-grained way these differences as we move forward. So Paul, I don't know if you have any comments or responses that you want to share.
Yeah. So thanks, Jeremy, for those comments. Yes. So basically, if you look at the issues that the guidance from the UNAIDS 2020 guidance document in terms of all options should be made available. So this is why basically right now there is that move to try and make things practical, right? You can actually be thinking ethical and aim for the highest standards that are not achievable at the end of the day. So I agree with you that the UNAIDS guidance, the draft still needs a lot of work, and I hope that colleagues from all over the world will continue to provide feedback to this particular process. Regarding the use of the HIV prevention options, so the tension, the tension has to do with the fact that when you are looking at the aim of HIV prevention research is actually to come up with more effective options at the end, right? And yet, if we are going to throw in some lots of options here which are very effective or which make things difficult for interpreting the results, then it actually means it becomes difficult to get to that end point where we are looking at producing more options that are workable for the different individuals and communities.
Yeah, thanks, Paul. So I see we're running low on time. I just want to see if there's any other questions from participants. Encourage anyone who would like to ask a question to feel free to unmute. Okay. Well, I'm sure there are. I know there are many questions in this area. You know, including what it means to receive a prevention package, and I think your example from, I believe, Malawi, Paul, is very illustrative of you know, individuals who receive packages then may do different things with what they're provided, whether it's information or actual biomedical intervention. So lots of questions out there, and we're not able to address all of them, of course, in this webinar. But I think you've stimulated some of these, some thinking.
Hi, sorry, can I just interrupt? It's Catherine Slack speaking.
Oh, yeah, please.
Hi, so sorry, I was on mute. Please forgive me. I just have one comment to Paul, and I wondered if I could just take the last couple of minutes just to ask him this.
Yes,
Paul,
please.
Congratulations, it's Kathy here. Sorry to miss the beginning of your talk. Paul, you were at the UNAIDS meeting to revise the guidelines, and I just wanted to ask you, whether you thought that with the UNAIDS revision, and certainly with the kind of ethos in that room, certainly seemed to be that UNAIDS really wanted the revision to much better adjudicate the claims of participants for HIV prevention against the claims of at-risk citizens. And I think they really wanted to try and make sure that their revision to the draft guidance points sort of better reconcile those two claims. And I just wanted to ask you whether you think that if they can do that, that we're going to have a landscape where the two major documents, the UNAIDS document and the HPTM document, where there's just much better handshake between the two and much less divergence in approach, which I think would be better for most of the stakeholders. And do you see it that way, or do you think I'm barking up the wrong tree?
Thanks very much, Kathy. So basically, if I look back at the UNAIDS meeting, they were also, you see, if you're looking at the participants, right? At the end of the day, the voice of the others who are not necessarily the investigators is actually louder when you're looking at the UNAIDS process as opposed to the HPTM process. So this is why you tend to have that particular divergence, because if you're looking at the HPTM process, the voice which is kind of louder is that of the researchers and the sponsors, although other stakeholders are coming in to chime. But basically, you know that as a network, the voices that carry the day are those of the network itself. So hopefully, as we continue discussing those draft guidance document, we might actually end up coming to some position where it becomes possible to conduct research which comes with clear answers for society. At the end of the day, it's important to emphasize that everyone who is on the table is focusing on coming up with effective HIV prevention options, including the community representatives, including the regulators, and also including the sponsors and the investigators.
Thanks, Paul.
All right, well, with that, I think just thank Paul again for your presentation and for joining us today. And thanks everyone for coming online. I'm sure this will be the new normal for the next few weeks as we sort through the coronavirus. But thank you again, and we'll look forward to sharing information about our next webinar in the series. Thanks, everyone.
Thank you, Joe, and thanks everyone, and stay safe.